Welcome to LHIS LinkedIn Live. This is HETT's Leading Healthcare Innovation Summit, and we're going to be discussing the 4 pillars of healthcare digital transformation this afternoon. I'm Sam Shah. I'm the chair of the HETT Steering Committee, and I'm joined by 3 excellent panelists today who are going to be taking us through their views and thoughts on many of the topics that we'll be discussing at LHIS later this month. You can join LHIS by signing up with the link that will appear in the comments. So do scroll through on the comments on the LinkedIn page, and you'll find the link to joining LHIS if any of you want to sign up for that. If you're adding any comments or commenting online, please do use the hashtag LHIS23, and you can follow us on Twitter at HETShow. So I'm joined today by 3 panelists who will be talking us through their views and thoughts on many of the topics that you'll be familiar with, but also be able to join in if you come to LHIS later this month. And so we have Tremaine Richard-Noel, who's head of emerging technology at Northampton General Hospital. We have Tristi Tanaka, who is the head of the CMO portfolio at NHS Black Country Integrated Care Board, and Videha Sharma, who is National Medical Director's Fellow, NHS Transformation, and also a lecturer in Health Informatics at the University of Manchester. Welcome to all of you, and thank you for joining me today. Throughout the discussion, our audience will be able to post their comments and their questions, which we're able to take towards the end of this discussion. So for everyone listening and has joined us today, please do post your comments and questions as we go through. I will be posing them to our panelists, so please do make them really, really difficult, challenging, and think of those questions that hopefully our panelists will stumble on and won't be able to answer. But without much more, well, first of all, thank you to all 3 of you for joining us. How's your morning been so far, Tremaine?
Busy, lots going on, as always. So.
Lots going on in the trust, probably no shortage of projects that you're working on, I'm guessing.
Yeah, there's so much to transform in the digital space, right? So never a dull day.
Fantastic. Videha, how have you been?
Yeah, very good. Thank you. Thank you for having me on this afternoon. Doing very well, very exciting. Working on some interesting projects at the moment, both regionally and nationally. So having a really good time.
Fantastic. And Tristi, I think you're still with us. You may have come off camera, but if you're still there, how have you been today? We might have momentarily lost Tristi. Well, we will move on to some of our topic areas and questions. We're going to be covering 4 pillars, the 4 pillars that form up the actual program on the 23rd of May. So you'll be able to hear much more on the day. But I'll start off, Tremaine, with you. And just thinking about the big topic that has come out of multiple reviews about the shift in digitization, and thinking about things like, how do we consider the benefits of greater productivity in supporting the NHS recovery? I suspect something that forms part of a discussion every day for you. How's that going, and what are your thoughts on this area?
So I think what's interesting is it's sort of changed over the last few years as technology has shifted. So it previously was sort of thinking, how do we get big bang systems to really overhaul ways of delivering clinical care, and that typically involved more technology sort of folk, and then saying, okay, clinicians, what do you want now? Whereas we've moved to those sorts of solutions that are way more customizable, and actually technology is now in the hands of clinicians and becoming increasingly so. So suddenly it's gone from actually how do you do transformation in a huge way to how do you enable people to do transformation at a local level with their own ways of working and support them doing it, which I'm finding a big shift in the way that we're working. So we're suddenly, I spend more time working with clinicians and understanding processes than ever. I literally ran from the last meeting from a service surgery to here, where it's understanding their workflows. So I think it's very much like we've moved into a world where you can really embed it in what you're doing and change. So it's changed the way we deliver things, really.
And on the ground, that it's great that there's some traction and discussion around change. Are you also feeling the pressure of the need for recovery? And is there a real impetus and drive to use technology for the recovery effort?
Yes, although I think what I've taken from sort of conversations post-COVID are there's less of a desire to just make what we do better and more of a desire to transform the whole thing. So as an example, you talk to clinicians and you look at things like referrals, and it's sometimes the issue is with what others are doing around them, not what their process is and how they work. So I think there's a huge desire out there. I think the challenge is everyone's got different tool sets, and that's another challenge. But I think the appetite is there. I think obviously the challenge is with capacity to do some of these things. But it has shifted, I think, in terms of people are feeling more confident about using technology as a tool to change.
Tristi, I'm really interested in your perspective on this, and we were just getting to the discussion around NHS recovery and what the technology effort might be to support it. Now, you've got an entire integrated care board, integrated care system to look after, and not just one hospital or provider entity, but of course, the entire lot, the primary care, partners across primary care, the acute providers, urgent emergency care, mental health, community, and I suppose to some extent, social care as well. What are you finding around the use of emerging technology to support the NHS recovery effort? Is that something that's universal across the integrated care board, or is it still something that you're having to take people on a journey for?
I wouldn't say emerging tech is universal. I think just speaking from the Black Country experience, a lot of it has to do with where the system is in its readiness to have those kinds of relationships to talk about emerging tech. And I think the transition period from CCGs to ICB has been one that's taken probably a bit longer. The different ways the Black Country has explored and is exploring those relationships to enable the types of benefits you can get from emerging technologies in the future would be through collaboratives. So there's a very strong acute collaborative. There is an emerging lead provider collaborative for mental health, and our primary care collaborative. Alongside that, you have the other transformation programs, right, which includes understanding place-based partnerships and the development of integrated care partnerships. So the ICB is a busy place to try to understand all of the different stakeholders. So when Tremaine was talking about transformation and digital transformation in the acute setting, that's quite a different space to be working compared to primary care, where you might organize into primary care networks or federations. And in the Black Country, it's primary care and networks. So a lot of that is a much lower level unit of organizing, so smaller groups, but lots of them. And I think that's part of the challenge with some of the technologies. You might need to start small with a smaller group of folks that are interested in the change and see incrementally how you might be able to bring those out to others as they carry on with their operational changes that are happening.
Tristi, it's quite fresh. In fact, not even a day old. Of course, we have the recovery plan on primary care that only just came out yesterday. Any early thoughts on how primary care is going to make a digital shift, being one of those lower units?
That's a good question, Sam. I think there are a lot of priorities in train already, lots of projects and work streams. So I think the first bit will be that the leadership are able to recognize which ones they should continue on with, and maybe others they might have to prioritize over. That's always a challenge, I think, in the public sector, is prioritizing and then stopping the things that actually don't hit that list until they are able to move forward. Is that
and
okay?
Sometimes difficult for us, right, to stop things as well. Not something we're often used to doing in any health service, but a real challenge to any policymaker, funder, manager, and even clinician in this space of how do we stop doing some things and instead do some other things. By the way, for anyone that's just joined us partway through, please do post your comments, use the Twitter handle @HETT Show, or feel free to use the hashtag LHIS23, both posted within LinkedIn and on Twitter. And if you'd like to make any comments, do make some comments, because I will pose those to our panelists today. Thinking about another dimension and an area we'll be talking about more at LHIS is workforce, and thinking about the future landscape of workforce. There's been no shortage any one day of the week on commentary around new workforce, changing workforce, reskilling workforce. But a big problem, of course, is the retention of our workforce, and how do we both, of course, recruit and onboard more members of the workforce, but most importantly, how do we retain that workforce, and at the same time foster this culture of digital first. I guess all of you here probably involved in this, but Videha, I might come to you first of all, both from a sort of clinical perspective, but also your national view on this.
Yeah, thanks, Sam. This is a really, really important topic and something that's very close to my heart. Whenever I'm in the hospital, I always take the opportunity to speak to my colleagues, particularly more junior colleagues, to ask them what their challenges are as they try to navigate a career in the NHS. And sadly, one of the recurring themes that particularly, this is my medical colleagues, kind of a foundation level, share with me, is this challenge around pay. And this is a difficult topic, and I'm not sure if it's fair of me to bring that up, but it is something that I hear recurringly. So there is something around that, and of course we've had junior doctors going on strike recently, as well as lots of other healthcare professionals sharing their discontent with how they're being compensated for their work. So I think that is a topic that's important. It's a difficult one. It's not one that's easy. It's of course very politically charged, but it is one that we need to have. So I think that's maybe a heavy one to start off with, but I do think that's important, which is why I wanted to stress it. Following on from that, there's a big challenge for us as healthcare professionals that our work is changing. So even in my relatively short career as a clinician, my work as a doctor or as a surgeon has changed over the past 10 years. The way, certainly in an acute setting, the way hospital services are delivered are changing. There is an increased centralization of specialist services, which means that the care models are changing, care pathways are changing. The perhaps more traditional ways of setting up hospital teams, which were perhaps based on a single consultant having a team of registrars or juniors that work as part of a single team. That model is shifted for many right reasons, but it has changed the experience that healthcare professionals have on the shop floor. And in some ways that is less attractive, and it's less the sense of team spirit, or the sense of working towards a unified goal has reduced, and people share an experience of being a cog in the system as opposed to being a part of a well-oiled machine, if you like. So I think these are a few things that we need to really critically think about. And then the final piece is, how do we think about technology to make that work more attractive, make that work less burdensome? And a big part of that, I think, certainly from speaking to junior doctors, and I'm a junior doctor myself, is around the administrative burden. So every part of clinical practice today is technology enabled. There's no encounter with a patient that doesn't happen with a computer screen as part of that experience. However, there's a question that's to be posed as to, does that computer screen potentially create a barrier between the patient and the healthcare professional? Does it limit the experience that both the patient has as well as the caregiver has when they're delivering care? So can technology change that by taking away some of the administrative burden, automating processes? Absolutely. But I think, and Tremaine started off with this point at the start, which was fantastic, this needs to come from the ground up. So clinicians need to be empowered to be able to identify and share their pain points, share their challenges, and be able to drive change from the ground up. And that's not easy, but that's certainly what I'd love to see happen more.
I'm glad you mentioned empowered there, because I think Dr. Rahul Goyal, who's the Chief Medical Officer, Elsevier, also mentioned empowered clinician in the digital space in the comments there. Right. Probably a theme that sort of resonates with a lot of people, and perhaps one that will come up again during our conversations on and during LHIS. Tristi, I would like to come to you on this topic too, because Videha has posed quite a fair challenge and really set the commentary on today's problems around retention of the workforce, stemming from pay, terms and conditions, and all of those things first. But alongside that, having to sort of drive digitization in the workforce. But from an ICB lens or a system lens, there's lots of discussions about skill mix, use of others in the workforce to perhaps take off some of the burden, transfer some of that caseload. What sort of digital tools are you seeing being applied, put forwards to help support that workforce in that skill mix?
That's a good question, Sam. What tools are they using? My observation is that a lot of the interactions to understand what can be done is still quite traditionally oriented. So lots of meetings, lots of stakeholder meetings, lots more stakeholder meetings.
And from those stakeholder meeting discussions and from the ground up, are any clinical colleagues coming up with new things they would like, or things that used to exist that haven't yet been implemented? Decision support or any other tooling that might help them in that skill mix?
I think those types of projects tend to be more passion projects in particular spaces. So definitely the trusts have some of that capacity and some of that innovation happening. And in other spaces, I think there's a lot of baselining, if you like, making sure that they've understood the fundamentals of the ways that we would want to look at changing the workforce. In systems which are very hierarchical, it's quite hard to understand what the rest of the world is facing. I think there's something a bit insular sometimes. So I'm not speaking about the Black country now. I'm going to speak about wider about the NHS. There's something a bit insular about the NHS in the way that it thinks and designs recruitment campaigns. It's almost chicken and egg at times. To be able to get in, you need to have health experience. However, how do you get health experience if you've never worked in health? Which then maybe drives an academic route. Again, if you haven't had operational experience, very hard to get into some of those roles. You might be able to skip quite a few of those by coming in at a higher level, but that means you've already committed down a different route and have found a way in. So I'm kind of changing your question there, Sam. But I am quite keen on understanding a bit more what folks think about. We're facing a really interesting time with multi-generational workforces now. In I think it's up to like 5 generations or 4 generations in one workspace. You can have that. And I have to say, with my 2 teenagers, their worldview on technology is very different than the one that I grew up with. At the same time, if we're talking about skills mixes, then I would love us to see us looking more at transitioners and returners who might have different industry experiences than just health, and help them understand those challenges that they could feed into that health and care teams are facing. Remote and hybrid working remain an important part of the offer to folks that are coming in from different parts of the country. And just a conscious awareness of maybe requiring the face-to-face, a lot of bums in seats. Just a caution on that, because there is something about losing the opportunity to get folks with a wider skill set, lived experience to be able to bring into service design, which I think is much needed for some of the challenges facing services now as they continue to operate.
And I guess that's a really important point, particularly around as we try to change services to bring in those people with digital skill sets. They might be used to working a different way that may not fit in with what is a traditional NHS way of doing things. And so I guess it's about openness in the way we recruit, who we recruit, and recognizing the flexibility that might be needed in people's roles, working patterns that retain those individuals in the NHS. During LHIS, we'll cover lots of topics, but another one that comes up time and time again, and again, something I see every day, is the question about interoperability. I'm sure ICBs are all busy trying to tackle this across their systems, and with a greater sort of demand on digitization, whether it happens to be connecting data, whether it happens to be IoT, virtual wards, if they exist, remote devices. I suppose interoperability is something that we have to tackle, especially if we want better outcomes for patients. Tremaine, I might start off with you here, because you're in a setting where I suspect you've got everyone coming at you as an organization, trying to get you to connect to everyone else. How are you solving this, and has anything progressed in the last 2 years?
Yeah, so I think where I'd start with it is I don't think people understand generally what interoperability means. So
I'm hoping you're going to give us a 101.
Yeah, no, I'm not just going to drop that. But I think so traditionally, interoperability, people sort of think, does this system connect in or not, right? But realistically, that's a very binary view of the world, because when you drill down into sort of interoperability, yes, certain systems can pass certain pieces of data in certain ways. The way that I think that we need to be looking at things is interoperability is all about data, and do individual clinicians and non-clinicians alike have the right pieces of information to do their job at certain points in the journey. So I think especially with recently with all the outpatient technologies that people have purchased, as a perfect example, right? You under the hood, you see, yeah, they've got API functionality, they've got all of these good things, but that just means the data flows through. But clinicians aren't hooked up to a database through some weird sort of connection, right? So there's a sort of reality of, yes, the system may talk, but have we designed the application of that in a way that makes sense? Also, we don't have teams on the ground that can build point solutions that help connect processes. So you look in the US, and even with a fully fledged EPR, people are still building small point solutions that may work really well for delivering a cardiology service, but we don't have those teams readily available that can do that sort of thing. So I think that, in short, yes, it's one of those things that we need to start with. What are people trying to achieve? How do we want to redesign and design the new ways of working? And then what systems do you plug in to do that? So almost people have started with, what technology do I buy, and then work out how I plug it in, as opposed to what problems do people have on the ground that we need to solve, and then what technology do you need? So I think we've seen that shift where, with our program as a perfect example, we started purely as people are using robotic process automation. Can we help people using it? So we started very much with a tech focus, and then realized it's all about process. So we've turned more into a process consultancy that then, ironically, 50% of what we do is not automation. It's saying, don't use it, because actually you just need to change something there. Well, it's already got a functionality, no one turned it on. And it's this shift as well with, I was reflecting on this yesterday, talking about AI. So this question of people say, do you set up an AI function in your organization? And it's kind of no, because you need a solution. You only need it if you've got a functioning team that has virtually looked and said, yes, that's a problem I need AI for. And then realistically, those expertise are really expensive to do in every organization. So I think we need to get better at sort of building capabilities that organizations can tap into, and linking back to other things that are going on as well.
And do you find, this you might find this difficult to answer, but are there lots of situations where either a supplier of tech is almost coming at the organization with a solution, looking for a problem that may or may not exist, or sometimes do you find that across the system, with the best will in the world, people are often trying to implement a technology solution across NHS partners where they may not even really be the business need for that solution?
So starting with the first bit, I think the vendors aren't so much of the issue, in the sense that I think we all have shiny thing-itis, in the sense that, you see something, it looks good, we want to do it. I think the challenge is that we're not really good at thinking of technology as a toolbox. So it's that when you zoom out and you look at what you've actually got, you think, we'll fix one point. But when you step back, you create what I've called Ferrari to horse problem. So you've bought a Ferrari to take you some part of the journey, but you've got to remove the blockers on the road. So you have to get on a horse and cart and continue. That's kind of what we do with our processes. So I think some of it is sort of working at an organizational level to understand what is the toolbox needed, what have people got, and how do you really push the solutions already there. And some of it, I know there's sometimes challenges with business, individuals just going off and getting their own thing. But if I'm honest, that's less of a, I think that's kind of a symptom of not knowing not having teams and support to actually go and identify your problems and then find the solutions, that people will just find solutions. I mean, I've done that. It might be on a smaller scale, but you go, I haven't got the technology for my particular problem, I go and get it. Now, I suppose the next step with all of this is, how do you support people on the ground, as we get more and more of these point solutions, how do you support them in implementing them in a way that is safe and effective? So what I mean by that is stuff like, like Power Automate and all those sorts of solutions. I'm meeting more and more clinicians every day that build their own solutions because they're fed up of what they've not got on the ground. And they're people coming and sort of confessional going, I've built this stuff. How on earth will I support it if I go, and what do I do? So I think we're moving to a world, especially with things like Chat GPT and others, where the options are opening up. Had to get it in somewhere, right? Where things are opening up in terms of opportunities and ways of working. But there's lots of stuff where you can affect your processes right in front of you. So there's suddenly like 2 layers of organizational infrastructure and solutions that you need available, and then giving them to people to design. But we need like standards and in a light touch way, because I think what I'm seeing is people build something, try and implement something, and then have a 50-page DPIA, a DTAC assessment, all these things to go through, and it's like, you're almost punished for being innovative, right? So, but with a huge amount of paperwork. So it's trying to find that balance.
I'm glad you actually brought that up, and we'll come on to that in a moment, because I do think, especially around citizen and patient-facing technology, this in itself is a burden I often hear about. The bureaucracy and the admin burden around it, the compliance on the one side, absolutely necessary. On the other side, feels like it can sometimes be daunting and difficult to navigate. And I would like to come back to this in a moment. But before I do, Tristi, I saw that you were vehemently agreeing with Tremaine there on some of his reflections. Any comments you want to make?
I think coming from outside the NHS, I've only been in since February of 21. All of these pain points are typical of every industry going through their digital transformation journeys. So it is a bit of, how do we pull in what the rest of the other industries that have gone through this process before, the best of that, so that health and care can do it with the benefits of what people have already learned. So Tremaine had talked about quite a few things there, one of them about getting to the problem, making sure that the problem you're trying to solve is actually for the people you're supposedly serving. And the other one is, he didn't say shadow IT, but that's the old school way of calling it shadow IT. I'm just going to build it myself because I can. And while we might encourage that in a safe kind of sandbox or discovery kind of mode, that's fine, except for then we need to do the grown up bit, which is to say, and how would we sustain it? Because money doesn't always flow, even though it's really good for you, it might not work beyond your team. And does it actually create problems somewhere else? I mean, those are things you will get from understanding business process analysis and having a stronger embedding around, let's say if we go again within the IT function, service management, understanding the interconnections amongst teams and processes when you're trying to deliver things together. And as far as I can tell, I've rarely ever come across a business analyst who understands business processes in the NHS. So if there are those out there, that'd be great. And then on the other interoperability side, where are the enterprise architects? I mean, industry has those right, left, and center. So how come we don't have them, understanding what the primary care architecture looks like for network connectivity all the way through to patient-facing remote consultations, right? And then if you want to look at it across the system, where are those architects who are able to then look at the interoperability needs across the different settings? So
and I guess that itself is a great challenge, right? Because where is that part of our digital workforce, and what are we doing to build that capacity, which is perhaps just as important as delivering, in many ways, complementary to our clinical teams. We also need our digital teams to support what we're doing. Tremaine, you want to pop in?
Yeah, I was going to say, I think what it needs to happen is, I suppose, more like if organizations can get beyond BAU, and what I mean by that is like some organizations just naturally just don't have a digital capability that can do anything other than keep the lights on. But if you can, I think the approach is suddenly different, which is you kind of have to turn those people into, you almost have to get the clinicians to understand the tech and the tech people to understand the clinicians and get them working together. And also that, there's a challenge in doing that, but that's the only way you're going to deliver on the ground in those sort of hybrid teams. And I think the other thing is we need to sort of be better at looking at what's already out there in terms of processes. So one thing I find particularly difficult is I did some research over the weekend around guidance around different models of care and process and all of that. And, almost everything has already been thought through. So, you look at things like GIRF guidelines, you're like, it's clear what you need to do. It's just the fact that to get there is quite challenging and not everyone necessarily knows that the guidance is there. So there's a bit around trying not to reinvent the wheel, but actually going, what are the things we all need to do and how do you get there? Because the get there bit is the hard bit that we need to support people to say, look, this is the end goal. What steps do you want to work on to get there? Because not everyone's got the resource, not everyone's got the best approach. And I suppose also kind of that proportionality of governance, because we are very much geared towards implementing EPRs and big apps, big solutions. So, we've got huge governance. We've got better at how do you do stuff like DTAP for applications, but suddenly it's less around taking stuff off the market and you can build your own stuff. So how do you govern those smaller bits? So I think the challenge I've seen is people are building very small parts, like how do I get data from here to here? And that's got the same governance as if you were implementing a massive system. So I've seen people do 4-step automations and trust going, shall we DTAG this? Because there's not quite an understanding of what you're building and what you're doing and what relevant safety assessments and things you need to do to align with that. So I think connecting all of that up is really important.
And it's that proportionality against the sort of end objective. I'm going to come to all of you on perhaps our final sort of discussion point before we move into the Q&A. And we have lots of questions from our audience, so we will go through all of them, in fact. And if anyone else would like to pose any questions out there from our audience, please do post them in the comments, and we will be turning to the questions in a moment. Before I do that, I will come to all three of you on this, because that whole thing about the outcome we want, whether it is the outcome for the citizen, the patient, and their position in their care journey and their experience, or reducing the burden and the pressure on clinicians and the system, those seem like outcomes we might want. And one thought is that patient-facing technology could help us in achieving this aim. But how does anyone go about evaluating the patient-facing technology and its importance, its benefit to the system? What have your experiences been so far around patient-facing technology and how it actually makes a difference in outcome, as opposed to being, my favorite term, another vanity project? So Videha, I'm going to turn to you first of all on this, because I'm sure you get patients coming to you all the time with their most recent gadget, app, or something else when you're seeing them.
Yeah, absolutely. I think there's probably two parts to this, or two kind of ways of thinking about this when it comes to patient-facing technology. I think one perspective is the kind of perhaps more commercially minded approach, where there is a new tool or an app or a piece of technology that's been designed for patients that's not perhaps gone through the more traditional academic evidence or the academic route. Those tools sometimes have very good uptake and are very widely used, even though there may not be lots of evidence or evaluation of whether they've got any kind of positive outcome or not, but they are widely used. And then there's also the converse, where within the kind of academic space or the more regulated space, tools are being developed and being tested very rigorously, evaluated for outcomes, lots of published literature and papers on, a heart failure optimization app that I can think of that was developed by colleagues in Canada, which has got loads and loads of evidence, but is not adopted at all. It's not actually implemented, it's not really been taken up by patients in reality. So I think there's a gap there, or there's something that perhaps the more academic evaluative space perhaps needs to learn about. How do we market our innovation, or how do we brand our innovation? How do we make our well-tested academic solution, how do we prevent that from being put on a shelf somewhere to catch dust? And how do we actually bring that into market? So there's something about that translational commercialization pipeline from academia into the real world. And perhaps there's also something around the more kind of commercially driven, kind of entrepreneurial angle to developing health technology that perhaps does need to be influenced by the academic or the more kind of regulatory or evaluation space to say, okay, you've got this really shiny tool and maybe you've done great market research, you've identified a gap, and you're going to fulfill this. But alongside that, it's also valuable because this is healthcare, it's about people's health and well-being, that it is appropriately evaluated. You can prove that it's improving outcomes, improving patient experience. So I think there's like a gap between what's happening in the academic evaluation space and what's sometimes happening in the real world. And I think there's something on both sides that needs to come a bit closer together.
I really like that concept, bring the two together. And for anyone that is listening, there are some really good frameworks. In fact, UK government has got a published framework on digital health evaluation that if anyone's interested, they should have a look at, because it does set out some of those pragmatic techniques that people could use, and I'm sure will form part of some of our discussions at LHES on the 23rd of May, if anyone's interested in joining. We've got so many questions that I am going to turn to the questions, and I know Tremaine and Tristi probably got views on the last point we just went to as well, which we'll come back to. Before I do that, I am going to turn to our audience questions, of which there are many. I'm going to start off with Josh's question on what are the most influential digital technologies impacting healthcare delivery. And I might start off, Tremaine, with you, given that your role in emerging technology.
Yeah, so I think there's a range. So I know stuff around automation, I'm obviously going to say is like transforming a lot, but that's more around gluing up solutions. I think the bits that are having the biggest impact are when people are improving sort of those heavier processes. So things like referrals, any technologies there, and e-forms that are linked into that. So really dealing with some of those challenges around recovery and backlog. I think there isn't one technology that is particularly, like for me, that's like, oh my God, this is the one that's doing it all. It's more, there are the ones that are focused around the biggest problems at the minute are the ones that are having the most impact. So I'm seeing a lot in that sort of, and you've seen nationally around like patient portals and all those sides of things of we actually don't necessarily have the right tools to solve some of the challenges we have. So those coming in and being used is essential. So yeah, that would be my view.
And on a similar sort of theme, Phil Evans has posted a great question there. And really, what is it that anyone looks for in a new solution, and how can industry partners better approach provider or NHS organisations to sort of get a seat here? And Videha, I might start with you, because you must have heard this both nationally but also locally as well.
Yeah, I mean, I think for me, and also thinking about the last question, the things that would get me, I guess, motivated or excited to work with an industry partner would be someone who describes or appreciates the importance of data in healthcare. So appreciates that any kind of tool or solution that is being brought into the healthcare space ultimately needs to support the access of data at the point of clinical encounter. So what I mean with that, and Tremaine, you highlighted, lots of kind of point solutions that are being, implemented all over the place. They might fulfill a particular need, but if they are unable to make the data that's captured as part of that solution available to other parts of the health system, you're kind of not fulfilling the wider needs of healthcare delivery. And so I would want a provider of any kind of solution, whether it's an app, whether it's a wearable that's collecting, health data, to say that, we collect, particular heart rate monitors, during sleep through a ring or something like that, but we capture this data using these standards, or, we adhere to these these processes which allow that data to be reused in other parts of the health system. That's, I think, something that I would be really enthusiastic about. And I would say, okay, you think beyond your own solution, you're thinking about what is the value that I'm adding to the wider healthcare system, to the wider care of that patient. So I think that's something that's important. So I guess companies that demonstrate the importance of data and are data-centric, I think are exciting.
And Tristi, you must have had lots of companies knocking at the door of the ICB, offering help. What do you look for, and how do you get to a point where you're working in partnership?
So I think the recurring items that come up. So firstly, do they recognize the standards? So have they done a DCB 0129? So everyone can say we're DTAC compliant, but actually that's the one for digital clinical safety. So can you produce a clinical safety review report? And if you can, that's a really good thing. In my particular, for the Black country, we have the second highest levels of deprivation in the country. So do they understand health inequalities? Do they demonstrate that the product or service that they're pitching actually addresses or reduces health inequalities in a meaningful way? Can they demonstrate that? And I would add on to that they also recognize digital inequalities, and therefore the inclusion groups that might be important to any system have been recognized in the testing of their solution. And so when they actually provide the case studies or the use cases of where their product or service is being used, that they reflect back on the communities that are in our system. That would be one really important thing. And there's also kind of making a distinction between direct care, admin, and where they're possibly looking at patient self-serving or the patient being directly involved, or possibly the carer, right? Thinking about what those kinds of asks are of the community, I think are something, and also sustainability are the new things that are coming into play around what I'm looking for from suppliers who are forward thinking. It's not just about pitching into the NHS for something that they can just add on or maybe only do for a year or two and then drop off. Does that kind of give you a flavor of the stuff that I asked?
It gives a sense of the sort of value add dimension to what you're both looking for.
I think they're essential though, Sam. This is all of the changes that digital transformation brings to achieve the outcomes that we're looking for. So the outcomes are not for the NHS, the outcomes are for the people of the UK. And they're not additions, health inequalities and digital inequalities and sustainability. They should be by design. So in some ways, I'd also advocate for privacy by design. So when we're talking about data there, Videha, I'd add that in too.
So another common topic area, and we've got an anonymous LinkedIn user who's posted this question, and I do want to sort of come to all of you on this, which is, how can we make augmented AI and similar technologies business as usual? Videha, it's an AI topic area, something that is close to you. What are your thoughts?
Really, really good question. So, it's really difficult, right? We've already talked about having to trying to implement new technologies or change things when the healthcare service is under extreme pressure just to keep the lights on or just to continue to deliver clinical services. So how do you drive transformation or implement new things in that context? Well, I think one of the challenges that I see when it comes to emerging technologies such as AI is that we are we're often good at introducing new tools and solutions at a small scale. So, any kind of new AI company that you look up will be like, oh, we partner with the NHS. We've done a pilot here. We've done a pilot there. And the challenge is, how do we go from pilots to populations? So, all these new startups and exciting companies that are kind of doing really, really cool stuff, they get kind of lost in that second valley of death where they need to try to scale beyond their pilots. And that's really, really difficult. How do we make that business as usual? I think we're obviously going through a recovery phase right now. So I think highlighting particular tools and solutions that are able to support with that. So, for example, I can think of an AI tool that helps stratify patients in an elective surgical waiting list and is able to better optimize the use of surgical resources. That's the kind of tool that not only is introducing new technology into the NHS, but is also addressing a really critical problem right now. So identifying the kind of key problems that solutions solve can maybe make it more business as usual.
Videha, thank you for really helpful reflections there, and a theme that I'm sure is going to carry on when we all meet on the 23rd of May at LHIS. The questions and the comments are rolling in non-stop, and I'm sure we're going to pick many of these up on the day. So for anyone that didn't get a chance to have their question asked now and answered or discussed, please do join us at LHIS on the 23rd of May, and we will continue the discussion, I am sure, and pose these questions again to our panels on the day. But thank you to Tristi, Tremaine, and Videha for joining me today. It's been a fantastic discussion as ever. I'm looking forward to LHIS itself. We'll be continuing this discussion and many more. Thank you to all our guests and everyone on LinkedIn Live that's joined us today in the audience. Do continue to post online, post your comments and questions, and people will try and interact. I'm sure after the event, this recording will be available when we come off air. It will soon be available online for anyone that wasn't able to perhaps join us for the whole event or wasn't able to get there. But thank you very much to all of you, to our audience, for listening, for participating, and your thoughtful comments. Look forward to seeing you on the 23rd of May at LHIS. Follow the link and do sign up. Thanks.